Hello everyone, today I'm here with another topic, that is acute respiratory distress syndrome, or which is also known as ARDS. Now, beginning with, let us know what is ARDS. ARDS, it is a life-threatening condition which is characterized by widespread inflammation in the lungs and leading to impaired gas exchange and hypoxemia. So definitely when our gas exchange will be lessened, or the person will be having a low oxygen in the blood, which will lead to hypoxemia. It is typically caused by a variety of causes, which can be trauma, pneumonia, sepsis, aspiration and inhalation injury. Now coming to the pathophysiology, ARDS involves damage to the alveolar capillary membrane, which will lead to leakage of fluid in the alveoli, and subsequently there will be pulmonary edema. This results in impaired oxygen exchange and also decreased lung compliance. The inflammation will cause further injury to the lung tissues, which will lead to VQ mismatch, which is also ventilation perfusion mismatch, pulmonary edema, fluid accumulation in the alveoli will occur, and decreased lung compliance, which will cause stiffness of the lungs. Now coming to the causes and the risk factors, direct lung injury. What are the causes of direct lung injury? Pneumonia, aspiration, inhalation injury, and near-traumatic. The indirect lung injury, which can be due to the secondary to the disease conditions like sepsis, trauma, pancreatitis, massive transfusion. Other factors are trauma, drug overdose, burns, and systemic inflammatory responses. Now this ARDS is also characterized into the phases. So let us know what are the phases. First phase is the exudative phase, which will occur within 72 hours. Here the fluid will accumulate in the alveoli, causing the hypoxemia and pulmonary edema. And they will be, in some of the inflammatory mediators will be released like cytokines, and which will increase the capillary permeability. Now the proliferative phase, this is the second phase, which will occur 4 to 21 days, and the lungs will attempt to repair, but there will be fibrosis, that is scarring of the lungs, which will lead to worsening of the gas exchange and hypoxemia. Now the third phase is the fibrotic phase, which occurs weeks to months. Here the lung tissue will become more fibrotic, reducing the ability to expand and contract. That is, the lung compliance will be impaired, leading to chronic respiratory issues. Now coming to the clinical manifestations. The first is dyspnea. Next is tachypnea, hypoxemia, cyanosis of the skin and legs, crackles, signs of respiratory failure, and use of accessory muscles and intercostal retractions. Now, the diagnostic testing of the ARDS can be done through chest X-ray, which will often show bilateral infiltrate, which is also known as whiteout appearance. Arterial blood gas, the arterial blood gas, it will be hypoxemia, respiratory acidosis, low pH, and the PCO2 levels will be there. Pulmonary function test will be, which will show decreased lung compliance and increased dead space. Pulmonary artery catheter used to assess the hemodynamics, example increased pulmonary artery pressure and low cardiac output. ECMO, that is extracorporeal membrane oxygenation, which is usually considered in the severe cases. Now the treatment and management, mechanical ventilation. So low tidal volume ventilation is given to the persons to prevent further lung injury. That is, it is a lung protective strategy. So the PEEP, that is the positive index expiratory pressure, which will help the alveoli to open. Prone positioning, shifting the patient into a prone position, which may improve the oxygenation. Pharmacological treatment, sedation and analgesia for patient to control and facilitate mechanical ventilation. Corticosteroids sometimes used to reduce the inflammation, but in some of the settings it is controversial to use this corticosteroids. Antibiotics to prevent from infections like pneumonia and sepsis. Vasopressors to manage the hypotension, especially when the patient is going into septic shock. Supportive care, fluid management, fluid restriction to prevent the fluid overload and worsening of the edema. Nutritional support, frequent monitoring of oxygenation, ventilation, and hemodynamics. Nursing interventions and considerations for ARDS are oxygenation and ventilation support. Maintain optimal oxygenation using the lowest possible FiO2, that is fraction of inspired oxygen, to reduce the oxygen toxicity. Provide mechanical ventilation, ensuring settings are adjusted based on the ABG results and the lung compliance. Monitor for complications related to mechanical ventilation, such as VAP, that is ventilator associated pneumonia, or barotrauma, that is lung injury to high airway pressures. Positioning, turn the patient frequently to prevent complications of immobility like skin breakdown and atelectasis. What is atelectasis? It is a collapse of the alveoli. Prone positioning, it is often used to improve the oxygenation by redistributing the perfusion to more healthy areas of the lung. Fluid balance, closely monitor fluid and intake. Try to take the weight of the patient daily. Administer diuretics as ordered to manage the fluid overload. Monitor for complications, that is VAP, ventilator-associated pneumonia. So that's why we used to give frequent oral care to the patient, elevate the head of the bed to prevent aspiration. Barotrauma and volutrauma, complications that usually happen from mechanical ventilation due to excessive pressure or volume settings. Then pulmonary embolisms to assess the signs of PE, that is chest PE, sudden dyspnea, and tachypnea. Then psychosocial support has to be provided to provide emotional support to the patient and family, as ARDS is a life-threatening condition. Sedation and possibly neuromuscular blockade may be used to ensure patient comfort during ventilation. Education is educate the patient and family regarding the progression of the disease, treatment goals, and expected outcomes. Provide information about long-term recovery and rehabilitation, as ARDS can result in prolonged hospital stays and even recovery periods. So here are some of the endless tips for you for ARDS. Prioritize interventions for patients with ARDS. The priority is maintaining oxygenation and ventilation. So remember, when there is a question, you have to prioritize these things. Ensure you are familiar with the signs of respiratory distress and failure, as well as appropriate interventions. Understand the pathophysiology. Recognize the relationship between the alveolar capillary damage and impaired gaseous exchange in ARDS. Be mindful of mechanical ventilation principles for ARDS mechanical ventilation settings. It is usually based on the ABG settings and the lung compliance of the person. No complication. Understand the potential complications, including the ventilator-associated pneumonia, barotrauma, oxygen toxicity, and how to mitigate these complications. And fluid management, always think about fluid status and how it will affect the patient's overall clinical picture, especially in case